Welcome to Season 4, Episode 2 of Clinical Toxinology webinar. Is it relevant for medical students?
We are honored to guide you all through what promises to be an engaging and insightful experience today. This webinar is organized by the Department of Emergency Medicine of Hospital Chancellor Tuanku Mukris. For your information, we also collaborated with several esteemed organizations and to ensure this webinar success, namely Remote Information Consultation Services, REX, Malaysia Society of Toxinology, College of Emergency Physician Special Interest Group in Toxinology, Malaysia Biodiversity Information System, University Science Malaysia National Poison Center, and Toxinology Education, Resources and Development. All right, so before we begin, we would love to make a few announcements that need to be taken attention of throughout the ceremony. Feel free to ask any questions through the Zoom Q&A chat box. The questions will be then addressed at the end of every case, and there will be a feedback form at the end of the webinar to receive your certificate of participation and the CPD points.
Now, let us begin this session by welcoming Dr. Nik Azlan bin Nik Muhammad, our head of module for the emergency medicine posting, to give his opening speech. Please welcome Dr. Nik Azlan.
Thank you very much, Yasmin. Okay, thank you very much, everybody. Assalamualaikum and a very good afternoon to everybody. And thank you for our international panelists and Professor Khaldun as well. Just a small opening speech is just that clinical toxicology, toxinology, is it relevant for medical students? And this is actually the only time actually we can actually touch on clinical toxinology, because in UKM, our attachment for medical students in emergency department is around 2 weeks, and probably we will extend it to another 4 weeks. So within that emergency posting, there will be a lot of teaching about resuscitations and trauma. So there is no actually session in the whole medical, up to what I know, is the whole medical course on toxinology, on snake bites, because the students will be posting somewhere else, like in medical surgery, and toxinology is a part of the emergency medicine. So it's actually very important, the things that we actually missed, and it will be this is the only time we can actually touch on this. So I would like to return back to the moderator. Okay, and thank you very much. Thank you, everybody, all the panelists, for attending this conference.
Okay, now let us meet our distinguished panelists for today. So we have a total of 3 panelists that we are so excited to meet, and are very happy to have you guys join us today. The first one, Dr. Jörg Blessman. He is an associate researcher at the Bernard Nocht Institute of Tropical Medicine in Hamburg, Germany. He was previously a medical doctor, physician specializing in internal medicine, infectious disease, and public health. In the field of toxinology, his work mainly focuses on the epidemiology of snake bites and the respective snakes, clinical studies, training of medical doctors and nurses in the management of snakebite envenoming, and community education in Laos and Vietnam in the Southeast of Asia. We are very happy to have you today, and we're excited to have you in our discussion today as well.
Thank you. I'm happy to.
All right. So the next in our line of panelists, we have Dr. John David El Comandante, a training coordinator at National Poison Management and Control Center in University of Philippines in Manila. He is also a founding member and treasurer of the Philippine Toxinology Society. And besides that, he is a board member of the Asia Pacific Association of Medical Toxicology and member of Asia Pacific Committee of International Society of Toxinology. So, hi, greetings, Dr. John David. How are you today?
Hi.
All right. Okay, thank you, Dr. John David. We are very glad to have you today. All right, so we'll go to the third and final panelist. We have Dr. Nikhil Paul, an assistant professor emergency medicine at Kasturba Medical College in Mangalore, India. He also served as the department lead for disaster medicine and wilderness medicine. Dr. Paul is also the founder and director of Outdoor Medics, an organization dedicated to providing medical training and support in the outdoor and wilderness settings. In addition to that, he is also a faculty member at the American Heart Association Training Center. Okay, so hi, greetings, Dr. Nikipa. How are you?
Hello, hello everyone. Yeah, nice to be part of this discussion. Thank you for inviting me as well. Thank you. I'm doing good.
All right, good. Great to hear that. All right, we'll go to the next part of our webinar.
Moving on, it is my pleasure to extend a warm welcome to all of you as we gather today to delve into the intriguing and critical field of toxinology. This field offers invaluable insights, and we are so excited to explore its many dimensions with all of you. So to begin, here's a little introduction to clinical toxinology. Now, toxinology is the study of toxins, essentially, and toxins are made by living organisms such as animals, plants, and microbes. And they may bring harm to other organisms, and these toxins could be delivered as venoms, which are injected through specialized mechanisms such as fangs, stringers, or spines, and poisons, which varies through ingestion or inhalation or even through direct contact. Now, on the right hand of the screen, clinical toxinology, it encompasses a broad range of medical conditions that result from envenomation by venomous terrestrial or marine organisms, or poisoning from the ingestion of animal or plant toxins. And today we will explore and focus on the approach and management of toxin-related injuries. Now, previously in episode 1, they had investigated, collected data on students' awareness and the perspective of on clinical toxinology, and their results shown that there were 34.2% were already familiar with the field of toxinology, while 42.1% were not well aware, and the remaining 23.7% were unsure. Now, before we dive into our episode 2 for today, we are delighted to share our findings from pre-webinar survey. So today we explored the students' confidence level in providing and sharing information on clinical toxinology to the public. And here we noticed that there is a noticeable gap in regards to their confidence level. About 55.6% of students had no confidence to convey information regarding clinical toxinology. And this might be because they're not well aware to the field of study beforehand. 27.8% were unsure if they were unable to provide comprehensive knowledge about clinical toxinology, as this might be due to their limited exposure to this field. Meanwhile, the remaining 16.7% were confident enough to convey this information regarding clinical toxinology to the public, maybe because they were already aware of this topic.
All right, so in comparison to the previous episode 1 survey results, our findings noted a similar pattern. Only this time we explored on the confidence level of the students rather than the awareness regarding clinical toxinology. So there is a slight decline in number of people who were confident enough in providing information or knowledge to others on clinical toxinology, which was only 16.7%. when compared to 34.2% of students who were aware regarding clinical toxinology previously. So this spectrum of awareness and confidence level will contribute to today's events vibrancy as we seek to foster learning, bridge knowledge gaps, and explore this subject more thoroughly. So we'll go into a bit details on the survey. So firstly, an average answers of within 2.5 to 3 value, which signifies a moderate to low confidence level, whether they are able to provide information on the appropriate safety and health-seeking behavior regarding toxin injuries. which include this listed aspect, toxin-related injuries as medical emergency, what is the appropriate healthcare facilities, the emergency services, and the role of RECS itself. Next, we have a range of answers of within 2.28 to 2.86, similar, showing that students were lacking in confidence to share knowledge on these aspects, such as the common presentation of toxin-related disease, the appropriate first aid measures, what is the various sources of the toxin, and the emergency hotline, guideline, or resources available, and what is the appropriate antivenoms in Malaysia. And last but not least, same goes with providing instruction or information regarding toxin injuries. Range of answers within 2.52 to 2.81. Also showed a moderate to low confidence regarding identifying a potential toxin injury, important history details, how to administer the appropriate first aid, where patients should be transported to, and the emergency procedure in such cases. So in summary, we can conclude that most students are not confident or unsure in regard to toxin-related injuries.
Okay, so without further ado, let's get into our main agenda, the case discussions. So for this session, we will invite the panelists for a discussion, followed by a short Q&A session, and the audiences are welcome to place your questions in the chat box during this case presentation. So beginning with the first case. Okay, so this is a 12-year-old male with no known medical illness, and the patient sustained swelling over the left foot after stepping on an animal in the sea. At the time, the pain score was a 10 out of 10. Upon further history, the patient was playing at the seaside and stepped on an animal. This was when the family immediately washed the affected foot and cleaned it with warm water and bandaged over the left cup. And another side note, his last tetanus booster was received over 10 years ago. So when he presented to the ED, he was alert, conscious, not tachypnic, he was comfortable. GCS was full at 15/15. His blood pressure, his vitals were normal, blood pressure at 111/70, heart rate at 93, SpO2 was at 100% in room air, respiratory was at 16, and temperature was 36.5. So he was given analgesia, and the pain score post-analgesia was 1 out of 10. The estimated time the foot was wrapped to when he arrived at the ED was about 2 hours and 20 minutes. And otherwise, on examination of the foot, there was swelling over the left foot. It was erythematous. The sensation was intact. Pulse was palpable. Capillary fill time was less than 2 seconds, and it was with full range of motion. So before we proceed, may I ask possibly Dr. Paul, what is your view on this case at this point of time, and how would you approach it?
Right. So for me, there's this history of the person stepping into waters, marine waters, of course, and comes in severe pain. Right. So as you rightly did, the initial vitals were checked, and you paid a lot of attention to assessing the pain. The pain score was 10/10. For him, in the year, the first priority would be to stabilize his vitals and pain management. We would go for appropriate analgesic of choice, depending, because his pain score was 10/10. We can go for a higher things like an analgesic of choice. Pain management would be the priority, and then stabilizing the vitals would be the priority at this point of time. And stepping over a bite, we would consider a lot of things in our mind when you have given a history of stepping over an animal. So animal can be anything at this, especially in the waters. You may have, it might be a jellyfish, you might be a different kind of a fish, venomous fishes are also there. Maybe a marine snake bite also. So we have to consider all those things at this point of time. We may have to do, at this point of time, we will go for it. We may have to examine the local area for further, to get further clues about that as well.
Thank you so much, Doctor. Okay, so if we look at the diagram, the pictures of the patient that we have on the screen here. So if we look closely, we do see some puncture wounds. However, there is no active bleeding. There is some ecchymosis, and there was no worsening of the pain and the swelling upon the arrival. And if you can see on the bottom left side of the screen, we have marked the level of edema that the patient sustained. And otherwise, there was no palpable or tender lymph nodes. And when they arrived as well, the mother did mention that he had stepped on a stonefish. So with this information, possibly another one of our panelists would like to give your input. What do you think the species was? And this was the initial management that had been done. So intramuscular tetanus toxoid of 0.5 milliliters was given. Tablet paracetamol was given as the analgesia, and he was continued on symptomatic treatment. Warm water immersion was done as it was advised for the pain, and these were the blood investigations done. So as for now, possibly I would like to invite Dr. Jorg on your opinion regarding this initial management, or possibly prior to that, was it appropriate and adequately managed, or what would you have done differently?
Well, I think I agree. Walking through the seaside, close to the beach in shallow water, maybe the stonefish is one of the favorite animal that may cause the symptom swelling and the puncture wounds of the spines on the back of the stonefish, and also, which is typical, the severe pain. Yeah. I'm not sure, but he reacted well to the pain medication. So he was 10/10 first, and then 1 out of 10 after the medication. So that is already good, I think. The paracetamol seemed to work. If not, I would move to a morphine preparation, for example, 5 milligram morphine subcutaneously for pain management, but it looks like that he is better with the pain. So there is no coagulation disorder. That is already good. And because he had a little bit of ecchymosis around the puncture wounds, but there's no coagulation disorder at that time. And there is only a high blood cell count of 18,000, but I wouldn't be worried that much at this stage. That may even caused by the severe pain and the stress hormone reaction of the patient with a severe pain. Yeah. And so at this point, yes, warm water immersion, I think it's recommended. I personally don't have experience with stonefish envenoming, but I remember that warm water immersion or hot water immersion better is recommended to reduce the pain. But I think the drugs are equally important. Yeah, that is for my side now.
Yeah. So what do you think, JD? Are you okay with the management? How old is the child?
He was a 10-year-old boy.
Okay.
We
We have a lot of this fish in Philippines.
have a different mechanisms of injury for our stonefish. It's usually because of stonefish is being prized as a Chinese delicacy. So some of our victims are usually the ones preparing the fish. And yes, we've been actually, I would actually give, I think, a better pain medication of choice, but it seems that paracetamol had already worked. I would actually do the same warm water immersion. There's a very good antidote for antivenom for stonefish, but unfortunately in our country we don't have it, and I think it's expensive. But if it's actually available, I would actually opt for administration of stonefish antivenom, which depends on the number of puncture and, of course, in the progress of the clinical progress of the swelling. Definitely, I'll try to monitor the progression of swelling, and I do recognize that there could be some forms of necrosis, and sometimes I can remember some patients would progress to necrotizing fasciitis because of two mechanisms. It could be because of the cytolytic effects of the venom, and secondly, it could be because of secondary bacterial infection. Considering that this is actually a marine organism as well, if there's actually progression of the swelling and there's actually fever in this case, I would probably treat it with antibiotics that would cover for marine organisms as well, marine bacterial organisms.
Yeah, so I agree with that. You have to consider those, but we have to have evidence of there is any secondary infection or not with a serial observation, right? So
Yes.
this one, the results are is
No,
only
no, antibiotic first. Yeah.
yeah. So this is the initial, and probably further clinical monitoring of the patient serially. What about the tetanus toxoid there? Is it kind of standard to be given for a child of 10 years old?
Well, ideally, I think he should be given that TDAP, the next dose of tetanus at 10 years old. So he should have updated aside from the toxoid, he should have actually updated the tetanus prophylaxis as well.
Yeah, so I'm not sure what about the situation in individual countries, but in Malaysia, I think they have the first three when they were still a child, and when they are, I think the last tetanus booster was at the age of 7 and then at 12 years old. So for this child, I think he's Malaysian. So most likely what you need to do is to ask about the tetanus vaccination status. So if he goes to school, that is actually already compulsory in the program. So he is actually already covered with tetanus immunization. So by right, it's not necessary to give him a booster at this age in Malaysia. So it depends on the individual countries and depends on who we are dealing with. So we have a lot of, let's say, the one in the waters of between Sabah and Philippines, we have a lot of nomadic sea people. The children may not be complying to the vaccination program. So for them, we don't know what's the status, right? So we will give initially, and then we have to follow through with completing the tetanus immunization for them with 3 months and 6 months. Okay. All right. What do we have next?
Okay. Thank you so much, doctors, for the insightful input. So moving on, this was the patient's progress. Afterwards, the patient had a mild low-grade temperature of 37.7 degrees. So tepid sponging was done. Otherwise, he had no headache. There was no dizziness, no shortness of breath or chest pain, and the other vitals was also still stable. And upon examination again, there was swelling up to the ankle, erythema up to the mid shin, but it was not worsening. His RPP was at 0. There was no active bleeding from the wound. Distal pulses were still palpable, sensation was still intact, the range of motion was still full, and there was no compartment syndrome. So what was done for the patient, an hourly PSP and RPP of the vitals were done, as well as a repeat blood FBC for the CK done at 9 p.m. that time. It was at 137 international units per liter. And they were advised to stop the hot water immersion at this point. So could I get some of the panelists on your opinions on the working diagnosis of this patient at this point in time, and how would you think the management has been done?
Maybe Nikhil, you want to? Do you think a patient has an infection already? or is it a generalized inflammatory reaction?
So right now there is no, I mean, like the sensations are intact. Range of motion is also there. There is no stretch pain as well. So compartment syndrome can be ruled out at this, and there is no evidence of compartment syndrome. Local erythema is there. Mild fever, maybe we'll have to follow up. Maybe the start of an infection, probably. Uh, Again, the need for hot water immersion. I would say pain management at this point. Maybe hot water immersion, maybe soon after the event might help in the. That's again, but now it has progressed. Probably infection is setting up. Maybe we can think of antibiotics. This time.
Okay, interesting. David, John, JD.
Actually, I'm curious to see what would be the image of the wound at this point. If there's actually difference on the time.
Yeah.
Yeah,
Do we
because
have any update of the picture of the wound?
Unfortunately, we don't. We only had the pictures when they presented at the ED.
Okay.
because if there's actually already evidence of like necrosis in the area, I see some ecchymosis. At least for evidence of necrosis or progression of wound, then I would definitely treat. But fever alone could there's some signs of ecchymosis. And puncture wound, I would actually surmise that there could be beginning infection, but of course it would be dependent on the clinical progression of the puncture site.
Do you have any because this is still very early. You don't have the
Yeah.
culture, but do we have any kind of a broad spectrum for marine envenoming like this, marine injuries that we want to consider the antibiotics choice?
Definitely. So usually you would have your pseudomonal. You should cover for any pseudomonas in that case, and we have a particular marine bacterial infection that I'm really scared of, because we had already 2 deaths occurring with simple punctured wounds, but not really envenomation, but it progressed to to fatal necrotizing fasciitis, a Vibrio vulnificus infection.
So
So
Vibrio, right?
yes, so some physicians would tend to overtreat. So aside from them giving pseudomonal coverage like fluoroquinolones or sometimes some penicillins with pseudomonal
Doxycycline.
coverage, they will add doxycycline in their regimen.
Okay. Yeah.
Okay, thank you so
Okay.
much, doctor. Yes, and this is all we had up to the patient's progress, and this was the suspected culprit behind the patient's presentation. So, like we had mentioned just now, it was a stonefish. Any guesses on what the species is? Maybe we could get maybe Dr. Yorg to have a guess.
I'm the wrong person to ask for the speech. But what I'm thinking about is in this case also you always have to consider that part of a spine is resting in the wound, broken and rest in the wound, and that maybe have to be removed by a surgical intervention. That you have to keep in mind, I think. But actually, I don't have experience how often that really happen, but I heard that that may be a problem that cause then also infection.
Yeah.
But I don't
So
know.
yeah, because there's a slightly different in the spine strength ataupun the brittlety of the spines in stonefish. They appear to be quite
Rigid.
sturdy and quite
Yes, rigid.
strong. It's quite thick as well compared to, for example, the spines in a stingray. The stingray is very easy to break off, and they
Okay.
will break off after being struck into the soft tissue and broke off. But stonefish tend to be rather strong. Even it remains intact even if you step it when you are wearing the bootie, you know, the rubber boots for those who go diving. Yeah, that can be penetrated easily without breaking the spine. It's very unusual, and we had cases where people where you know, as JD said, people catch this fish to eat in Malaysia as well. It's a delicacy, and they keep live fish in the fish tank in the restaurant. So when they want to eat, they will catch it, put it up, and then they try to kill the fish first. And usually, sometimes they wear, you know, glove and so on. Even that, you know, when they try to strike the fish, it can penetrate the gloves. So it's quite a sturdy kind of the spines from the stonefish.
Okay.
Have you tried this before, Nikhil?
No, I'm yet to see a envenomation, and I haven't tried as well.
Have you eaten it before? Have you eaten it before?
No, I haven't
Because,
tried it. I'm yet to try, in
okay,
fact.
I've
yeah,
tried
maybe
it.
next
I've
time when
tried it.
you've tried it. Yeah, okay.
Yes. The flesh was really soft and
Yeah,
it's very expensive.
yes, very
Okay,
expensive. Yes. Yeah, next time, next visit to KL or Penang or Manila,
hopefully.
we can go for seafood. Okay, all right. So now the diagnosis is still remain as unidentified marine animal sting because there's no evidence of
Stonefish.
the fish that sting the boy, and no pictures of the animal as well. So we don't know because they are not. Stonefish is not the only one. The Cynicae is not the only species of stinging fish in the waters of Malaysia or even Southeast Asia. So there are many other things. So we diagnosed it as unidentified marine animal sting, but we treat it symptomatically. There's no antivenom for stonefish in Malaysia, but there is antivenom for stonefish, but it's only limited to Australia. So in Malaysia, we did not import the antivenom for this fish. So pain management, and also secondary infection is control is the method of management in our region. Okay, all right. Okay, so any other comment? Last comment, maybe. Any other comments about this case? Yeah.
Yeah. Only one thing I think we can go for a better analgesic than
Yeah.
that
Mhm.
paracetamol. I'm not sure
Yeah.
how tab paracetamol will help in, especially it's described as a horrible pain, like, so we may have
Yeah.
to go for opioids.
Yeah, but yeah, it's true. But when you start using opiates
Yeah,
for patients like this, then there's no more role for hot water immersion.
yeah,
So because it masks the pain, so there's no point using a hot water immersion, which can actually lead to scalding injury. So anyway, that's a good point. But apparently, the patient responded to PCM,
yeah.
right? Only PCM, only paracetamol. It's very unusual. Okay, that is very lucky anyway. I think he recovered well and went home without any sequelae. All right.
Okay,
Okay. So
so I'm going to try to pronounce the name of the species. The suspected species is still an unidentified marine bite, but it's a Cynicae verrucosa. So yes, as Prof and doctors had mentioned, this would not be the only animal that we would suspect, especially at the seaside. And of course, pain management, as the doctors have mentioned, would be the priority in this case to manage. So let's see. I believe there's one question that we have in the
JD,
chat
yeah,
box.
yeah,
Prof, is it okay if we want to address the question now,
oh
or
yeah,
shall we?
yeah. Can answer now. Why
Okay.
is still the case?
So the question is, how do we differentiate between toxic envenomation and a secondary bacterial infection in marine related injury? I may
Maybe
open it.
JD want to answer that. Yeah.
will actually still depend on the clinical presentation of the patient. Of course, in the initial stages of envenomation, that's why it's secondary bacterial infection. You should actually monitor. Some of the mistakes of some physicians is that they would actually tend to give antibiotic prophylaxis early in the course. Sometimes it's unnecessary because some puncture wounds would actually heal on its own spontaneously even without antibiotics. So it's actually a necessary cost. So it will really depend on, for example, there's progression of swelling, there's signs of necrosis, there's really changes in your laboratory parameters, and even actually if there's actually of course not, you would not tend to wait to wounds in sepsis, so of course you would actually be very vigilant in monitoring this case. I just like to also highlight that this is actually a pediatric patient, and the Sinusea verrucosa would actually tend to hide in unfamiliar places. So maybe a poisoning prevention, envenomation prevention strategy in this one is that for example, we have so many stonefishes in parts of Palawan. So we would actually always advise some tourists not to venture on places that they are very unfamiliar. So that's actually a strategy so that they would not encounter this species on maybe on beaches or to tourist sites. So it's actually very important for them, even though they've been, as Prof. Calvin mentioned earlier, even though if you're wearing boots, it will actually really penetrate the footwears because the spines. And it's actually very painful. The pain is actually out of proportion to the wound. So that's my thoughts about it.
Yeah. Yeah, I agree with you. We have seen people just jump into the water without without taking really note of what's under the water line. And I think the stonefish are quite if let's say in the beach area, there are a lot of other corals as well as stones
Yes.
formation and so on. So they are more likely in that area of the water. So you have to be careful. And we have several what we call fishermen who waded in the water at waist level, who got stung when they are walking in this area because they were trying to catch fish. So yeah, I'm not sure whether we have ever put up a signboard of caution for stonefish in Malaysia, but I think in Australia they put up in the public beaches to be aware about stonefish, presence of stonefish in the beach area. So they have to be careful. Yeah. So public awareness is still a bit lacking about stonefish. Anyway, okay. In the next case.
All right. So have a very good thorough discussion on the first case. Okay, kan? Okay, so let's move on to the second case. Okay, so we have a case of a 41 years old Nepalese gentleman with no known medical illness. He presented to the emergency department in a district hospital in Pahang 1 hour after an alleged snake bite while sleeping at night. He was bitten at the left upper forehead and the left parietal region, and thus developed swelling over the left periorbital region and forehead down to the left cheek. However, the right eye was spared, and he claimed that it was a green snake with thin body. So at that point of time, he proceeded to kill the snake and then left it at home. Otherwise, he denied any complaint of chest pain, no shortness of breath. He had no fever, no gastrointestinal loss like diarrhea. There's no nausea or vomiting, no palpitations, and no unprovoked bleeding. So we have a picture of the snake that he took at home. All right. So on the right side is the picture. So may I ask if any of our panelists would like to guess? Maybe Dr. York Blessman?
That is definitely a green pit viper, so a Trimeresurus species. I'm not 100% sure what kind of that is. That may be Albolabris, but maybe also another Trimeresurus species. I don't know the size. It's difficult to see on the left picture, the dead specimen there, but it may be not too big. But it's Trimeresurus, green pit viper.
All right. Thank you, Dr. York. So yes, it is a green pit viper. So after they already discussed with the REX organization, they decide that the species was specifically is a Trimeresurus sabahificatus, which is actually a green pit viper. Okay, so let's move on with the initial presentation at emergency department. So patient is alert, ping his Glasgow coma score was full, 15/15. Warm peripheries, capillary refill time was less than 2 seconds, and he had good pulse volume. His vital signs are all normal, but pressure 130/89, pulse rate 79, respiratory rate 20 beats per minute, temperature 36.5. He was febrile. Oxygen saturation was 100% under room air. Dextrose was slightly high, 7.9, and pain score at that time was 10/10, which is severe. So on local examination of the beaten area, noted the left forehead to the left cheek swelling. However, there's no obvious bite mark on the forehead or the scalp, and there's no active bleeding and no necrotic patch swelling. On palpation, it was tender. Otherwise, the all other system was unremarkable. For cardiovascular, respiratory, abdomen, and central nervous system was all normal findings. Yeah. So before we move on to the initial management, may I ask maybe Dr. Nikapal whether how do we approach this case and what do you think of this presentation at this point of time?
Right. So this case, as it's described as a snake bite, and we have also the picture of the snake. That's a green pit viper. On examination, we can see that there are signs of local envenomation. We have a swelling over the face, and there is no signs of a systemic envenomation. There is no too profuse bleed, or we also don't have any other system-wise looks okay. Like there is no renal involvement also, as I can see. We take it as a local envenomation as of now, but definitely requires further monitoring to see for signs of systemic envenomation, maybe later. Um, in our perspective, we manage any snake bite in our part of the world because we go by a syndromic approach rather than focusing on which snake it is, because uh, the history what they give can be unreliable at times. So we go by uh, a syndromic approach. We'll be looking for the clinical syndromes which develops after snake bites, whether it's a neurological syndrome or a hematotoxic syndrome. Also, we go by the whole blood clotting time as well. So we see for the whole blood clotting time to see for any signs of systemic envenomation, a hemotoxic picture as well. At this point of time, we can wait for the further investigations and see for the signs of systemic envenomation. For the local envenomation, we can progress for the spread of swelling as well and see for any necrosis which is developing up as well.
Good. Is there any feature of maybe setting in of allergic reaction or anaphylaxis in this feature
Yeah,
physically?
I mean,
What do you think?
looks there is a swelling on localized swelling on the left side, but
On the
there is
left
no swelling of other
on the right.
mucosal surface. The
Okay,
right
and
looks okay.
no rashes as well, right? We don't see
No right
except
looks.
for some erythema.
Yeah.
I think
other mucosal also is fine.
yeah. The left eye appears to be fully obliterated already, and this is on arrival to the hospital. Just I think less than 1 hour or a few hours after the incident. Any comment, JD? You have green pit viper as well in the Philippines.
Yes. Actually, I'm quite concerned with the eye. Is there a chance that it would develop into like profound swelling in the eye that would warrant ophthalmologic emergencies? That's one of my
Yeah,
questions.
that's what my question earlier. Whether is this a kind of a local, fully local, or is it already developing some allergic kind of features? But I think at the moment, as Paul said, Nico Paul said, is yeah, we treat it as a kind of an endemic for local at the moment. The question is, are we comfortable, just sit back and see, are we going to intervene with anything else? For example, antivenom or not. So because this is on the face, maybe what about York? Do you have any experience face bite by snakes?
Yes, I saw two green pit viper right in the face. So it's not it's relatively rare, but it's not that rare. And I would be a little bit concerned also about airways. Now you have to
Yeah.
be
Yeah,
consider
yeah,
whether the swelling is not going into the pharynx and then have an effect on the airways. That would be really dangerous. Then, so I would
yeah, that's right.
look into the pharynx whether there is already swelling, and then in these cases maybe go ahead even if the antivenom is usually not well working against the swelling, but then I would probably go for to prevent or try to prevent the swelling going and block the airway.
Yeah, so that's very important point because patient is sitting up or lying down. So as we know, if we know the anatomy, medical students need to know the anatomy of the head and neck. So you know the potential spaces. There's no real blockage between compartments of the forehead to the face and also to airway. So there's always a issue of patient sitting down like this, and the gravity will pull down the venom spread. Can follow the gravity as well. So that's the potential space that you have compromising your airway both from outside, also from the inside around the trachea, so around the pharynx. So open the mouth, ask the patient to open the mouth, look at the mouth, see really as well when you look observing the face, not just the face but also the airways. In this case, if there's any deviation of the trachea, changing in the voice, all kinds of issues with the breathing, wheezing, or stridor. Yeah. Okay. All right. So what do we do next?
All right. So I'll proceed with the what was in the initial management at emergency department. So
Ooh.
all the serial blood investigation was sent, and he the blood investigation noted was all normal findings, and he was given analgesics, which is in intravenous tramadol, intravenous fentanyl, and then was given fluid intravenous normal saline for pint over 24 hours, and then monitor to keep the saturation, oxygen saturation more than 95%. And for the antivenom, he was given 3 vials of green pit viper antivenom.
Okay. So you can see the progression is quite stark, right? Quite. Um, yeah. So
Yeah.
definitely airway is going to be a major
A
concern
concern.
here. Yeah. You can see already down to the pharynx area, down to the neck, the swelling has gone down. Just because of gravitational pull of the face edema. Okay, the eye is getting worse. Now you can see it's already tried to cross to the to the right side of the face as well. The forehead is already bulging with the swelling. You can see that. So it's quite dramatic change, right? And
Yeah.
this is the initial. We don't always trust just initial reading. We always do a serial reading. We do repeat 4 to 6 hours after the first bite, first result, And we are concerned here is the green pea viper. So we look at the coagulopathy, we look at the platelet count, as well as the white cell count as well. So at the moment, the initial looks quite normal, right? But maybe we can see the progress.
Oh,
Patient. So this is the
Okay.
this is the patient progress, which is it is worsening. So we can see the facial swelling now from the left cheek, involving both eyes, bilateral periorbital swelling, including the lips and also neck. And patient now has limited mouth opening, has increasing in the swallowing difficulty and also breathing problems. So in view of this compromised airway, he was then referred to a center hospital with anesthesiology and otorhinolaryngology backup, as this is only the district hospital. So after being referred at 14-hour post-bite, noted swelling already extended to zone 2 of the neck. And then there was restricted 2-finger breath, mouth opening, unable to protrude the tongue, and there was change of voice, noted a difficult airway. However, patient is still conscious. The GSCS score was still full, and patient was well perfused. And the lab investigation serial blood test was still unremarkable.
So Jörg, what do you think? Now both eyes are involved.
Yeah,
So
it's the best sign because I'm an opponent against antivenom for local swelling, and that is definitely something that we give antivenom and then the swelling progress really severely in this case.
yeah,
So the dangerous situation is that you will have total swelling in the pharynx and larynx and then stop breathing because of the swelling. So yeah, difficult situation if yeah, you have to be, I would say you have to be standby for laryngotomy in this case, I would guess. So, yeah.
okay.
I
That's
don't have a physiologist decide. You can also say, okay, we go for intubation directly to secure the airways, or you say, okay, there's not if there is a severe sign of airway obstruction already with wheezing or inspiratory stridor, then I would go for try to intubate, but stand by laryngotomy.
yeah, yeah. So what about JD or Nick?
yeah, I have a comment about this. So if the patient is presenting like this to us, I might be confused whether it is an anaphylaxis or again because of the venom. That is one thing. Second thing, what I see right now, he has a threatened airway. Of course, the mouth opening is very limited. At any time, we can lose the airway. Starting an anti-venom, I'm not that sure about the incidence of anaphylaxis following in the anti-venom administration also. So I would say I would prefer to intubate and then go ahead with anti-venom because again, uh,
Yeah,
yeah, that is
yeah.
also one thing you at any point.
Yeah, agree with you. So at the moment, I don't see if it is a clear-cut anaphylaxis yet, because the vitals are still remaining okay,
Yeah.
airway is still compromised, no, what do you call, rashes coming out. So JD, what do you think? At the 12-hour point before referring to the hospital, do you think you want to secure the airway first, or are you okay? I don't know what about the situation in Philippines. But for us, our transfer is usually with ambulance, and there's a medical officer on board ready to intubate if necessary.
Yeah. Actually, this is a very interesting case. Personally, I haven't encountered any pit viper bite in the face, so this is actually first for me. But given the situation in the Philippines that we don't have any antivenom for any pit viper, probably learning from this case, I would rather intubate him early and monitor the progress with the patient. Considering that this patient was already administered with 3 vials of
Yeah,
antivenom,
yeah.
right? Yeah, and still it progressed. So I'm really worried for our patients. Actually, I have a comment as well with the green pit viper. Is it
Yeah.
because from my knowledge, green pit vipers are usually ambush predators, so I'm not so sure why would the patient why would the pit viper crawling
It
in
could
the
be that
night.
could be a fall from the ceiling. I don't
Oh
know.
yeah, and it
Yeah,
fell. It's uncommon for
yeah,
something striking
usual to
like
be.
bongarus. Yeah.
Yeah, yeah, it's true. Maybe that's the story you provided us. So we have to take it with the benefit of a doubt. Maybe a bucket full of salt. I don't know, but anyway. Yeah, you're right. I would, I would be very worried transporting a patient who has something like this feature. But this feature is only taken when the patient already arrived at the other hospital. So maybe before transfer, they said it wasn't as bad as this. So therefore, they be from their judgment and looking at the time of transfer, the duration takes. Maybe they feel that patient condition not as severe to be prophylactically rescue the airway. Anyway, this is quite remarkable. You can see the progress is already down to the, definitely compressing now on the airway. But at that time, the patient was still breathing without any stridor, without, without any, compromise in the vitals there. So I
So
don't know.
this is actually double setup. So the airway, if they cannot successfully secure the airway, I don't know if they will be performing like surgical airway in this case, but that's
Yes,
actually
yes.
also difficult because you might actually run the risk also of
Yeah.
bleeding in this case. So I don't know if the team considered giving antivenom also prior to at least
Yeah.
surgical
So the
intervention.
antivenom, yeah, as you can see, the antivenom was already given, and that's probably the reason why the subsequent reading of the blood was actually remain normal. Because whatever, if it is the systemic envenoming, probably the first dose of antivenom has already corrected it or prevented from actually worsening,
Okay.
developing systemic. Yeah,
Yeah.
so that is the advantage of having the antivenom for it. So you can proceed with the surgical intervention knowing that the repeated serial blood is remain normal, right? But what I'm worried if it is a surgical is that this is already taken.
Yes.
So you want to do your surgical, how do you palpate for your landmark
Anatomy,
one?
yes.
Yes, and then okay, you can use ultrasound if you want, but if you have ultrasound, that's another question, right? So anyway, it's going to be quite difficult if you do a surgical intervention to the neck like this. So it's nice to be able to rescue if without any of these features developing at this stage. But it is like this. So what is our next move, right? So it's now going to be up to our colleagues, our airway experts, the anesthetists, to see how do we manage this. Okay.
Fiber optic,
So
maybe.
this is definitely not going to be just emergency management now. It's going to have a more specialized intervention. So we have to be a multi specialist attending this patient now. Okay.
All right. Just through all the approach as what suggested from all three panelists was similar to the what they expected to do. So in this patient, they did a flexible nasopharynx laryngoscopy and noted an edematous left side larynx and obscured vocal cord. So afterwards, another 3 vials of the green pit antivenom administered, and then they proceed with emergency tracheostomy because of the progressive swelling. And afterwards, the serial blood investigation noted no sign of systemic envenomation, and then the facial swelling started to improve. So this picture is after patient was already discharged at home. So we can see how it differs from patient initial presentation and the progress.
And here's a tracheostomy scar there.
Yes.
Yeah.
Okay. So I think he's lucky. I know it's a kind of on the dot kind of intervention at 14 hours means that already arrived at the hospital. And you can see that the progress was unable to open the mouth, swollen a bit of the tongue, and also edematous, and direct vision with the flexible laryngoscopy definitely confirmed the airway is compromised. So they did, I think they did the tracheostomy with assisting direct visual through the laryngoscopy. Yeah. So this is a kind of, I think, life-saving treatment, and it's just giving time for the tissue to heal with the top-up dose of GPAB from Thailand. So that's why, as you can see, if we give early antivenom, the patient most likely will not develop the coagulopathy. So in this case, it remains, we expect to be coagulopathy, but it remains normal. Even the platelet count did not go down significantly, or even the INR did not raise more than 1.5. So it's interesting that systemic is controlled, but the local is, you have to bear in mind, it's not, and antivenom does not, as Georg said, antivenom is not just correcting systemic. Local is going to be, take some time and maybe not effective. Yeah. So this is a good example, I think. Yeah. Last comment, maybe, Nick?
Again, I have this, in fact, like this is because I don't know about this. Like, how common is anaphylaxis secondary to antivenom over there?
Yeah.
Like
Yeah,
because
it's an issue, but I think we have studied. Maybe Dr. York can respond to this. Antivenom anaphylaxis.
Yes, possible that this is angioedema from the antivenom. Possible, yes. But when you saw the first picture there, the swelling went already onto the other eye, so
Yeah.
also quite. It's quite possible that is only a venom action, the
Yeah.
swelling of the whole face. I've seen two cases. One was a boy, and from the mechanism he was standing in front of a tree and was peeing, and then the pit viper got him directly on the front of his face. And the second case was a young woman picking coffee beans in the Bolaven Plateau in South Laos. So she was bitten also into the face by a pit viper, which was sitting in the coffee plant.
Yeah.
She also,
This is not our,
she also developed
yeah.
a swelling of the whole face, was a really terrible swelling of the whole face.
Well, was she intubated?
I actually
Or
probably not, because she was in a very remote hospital and stayed there. And I even don't know whether she finally survived, because I could not have a contact anymore. So they just sent some pictures, and I asked after, but I didn't get any answer. So she was in a very remote, small hospital near the coffee plantation, and she was could not be transferred to a higher level hospital. And
yeah.
I
So
don't know.
clinically, it's unusual to be having this feature as anaphylaxis, right? So
Yeah.
from the antivenom, yeah. So for us, we using the antivenom from Thailand, and our rate of reaction is actually rather low, less than 10%. And none of the features of the anaphylaxis appeared here, except for that unusual one picture at a later stage of bilateral angioedema. So anyway, JD, last comment about this?
Yeah, actually, although I think using polyvalent antivenom would really give you a higher risk of anaphylaxis as compared to monovalent.
We
Second,
have a lot of anaphylaxis out of
Yeah.
antivenom, in fact. So
Yeah,
we
but
have almost
you
30 to
go ahead.
50% anaphylaxis is there. So we will be in a dilemma whether to go for antivenom or securing the airway first, of course.
Yeah. Okay. So because you're using the big four, right? For
Yeah,
the
Big Four and Indian antivenom.
You don't have the green pit viper, but I think it's in
We don't
development.
have it.
Yeah,
It's in
I
development.
think it's in development. Yeah. Okay. All right. Okay. So a very interesting case. I hope the students learn something as well. This is one of the unusual. This is not our first time having such a case. We had a similar intervention with the previous cases as well, where the airway needs to be rescued and from intubation had because of prolonged, so he had to be using a tracheostomy as well. Take some time, 2 weeks if I'm not mistaken. Okay, so but all our patients survive so far. No death from pit viper bite in Malaysia so far that we are aware of, except for one, but that's because of complication from anaphylaxis. Anyway, all right. So okay, next case. Do we have?
All right. Prof, we have one question in the chat box.
Yeah. Okay.
Okay. So the question says, how can we differentiate between a venomous or non-venomous snake bite in the emergency department when the snake is not captured? So maybe we can clarify.
Maybe JD, emergency situation. How do you differentiate? The snake is not there. Luckily, this case we have the species, but patient come no species, no specimen to identify.
Yeah, I think Dr. Paul already mentioned how we would
Yeah.
be able to differentiate, of course, non-venomous and venomous spikes. Of course, we would rather go on looking into systemic signs of envenomation, the toxigomal approach, how we would actually see if there's actually symptom. And of course,
So
observation.
syndromic approach. Yeah.
Yeah, syndromic approach rather. So it's usually your observation in this case is actually crucial in determining which is venomous and which is not. I think it's different in Malaysia because our snakes here in the Philippines are really potent the neurotoxic snakes. So in minutes you would really develop a signs of envenomation and you would actually already easily differentiate the two.
Yeah.
Although for king cobra and pit viper bite, sometimes the effects are serious. Although for green pit viper, you will actually see profound swelling that would warrant further observation and
Yeah.
immediate.
Jörg?
Yeah, short answer, we cannot, I would say. But in this, of course, when you have a swelling, you know that it's a venomous snake. But you have
Yeah.
also venomous snakes without swelling, like the crates. So you always have to observe the patient for 24 hours for envenoming signs. And but in this case, with this a guy bitten by the green pit viper, even if you would not know the snake with the swelling, you know that is most likely a venomous snake.
Yeah. Okay. So yeah, call Rex. We can help you.
Yeah, correct.
If you have any doubts, just call Rex. Okay. All right. So next case. Shall we move on? Yeah. We have time for another case.
Yes. Okay, so moving on to our third case. So moving on to our third case. So this is a 23-year-old female with no known medical illness. The patient works at the Butterfly and Reptile Sanctuary in Malacca, and she was in charge of taking care of the reptile animals there. So while feeding this lizard, the animal suddenly jumped and grabbed her hand, and she sustained a bite over the left thumb after she tried to open the animal's mouth with the left hand. However, she managed to escape in less than a minute, managed to wash both her hands under running tap water, and post-trauma, she developed pain and swelling over the right hand, shortness of breath. She vomited 3 times and had 1 episode of diarrhea. Her pain score at that time was 2 out of 10. And upon further history, we found out that the patient had her gloves removed when this happened. She claimed to have used the tongs to feed the animal, and she might have not had proper training to handle this animal.
So she was bitten twice, right?
Yes, so the animal had grabbed her right hand And when she tried to open the animal's mouth with her other hand, she was bitten.
Okay.
Okay.
All right.
So yeah, when she presented at the ED, she came 1 hour post-bite. However, we have no picture of the wound after when she presented initially 1 hour. After that, her GCS was full. There was good pulse volume. Catheter refill time was also less than 2 seconds. She was not tachypneic and she had warm peripheries. Her vitals were also stable, as stated on the screen here. Lungs were clear. Cardiovascular examination was also not non-remarkable. Her abdomen was also soft and non-tender. Blood investigations were taken, and they had an ECG done. However, we have no picture of the ECG, but there was QRS of 88, QT at 250, and her heart rate was at 91 with good sinus rhythm. So before we proceed, I think I may show a picture. We actually have a picture of the animal behind this. So this was the animal. It was about a foot long. Possibly, any of the panelists, if you had encountered this animal, do you happen to know?
Dr. Yerkes always find this in his dream.
Well, look like it may be when the patient has swelling. I mean, she will know it's maybe a Gila monster, no?
Yeah. She works in the sanctuary. I'm sure they know what it is.
Yeah.
Yeah.
So they
But
know.
yeah.
But
So
it's
what's the diagnosis? Gila monster. Yeah.
But it's not an animal in Malaysia, no? It's in Mexico, I think.
No.
Yeah.
Yeah.
Mm.
US.
And
Yeah.
US, South US. Yeah.
Yes. So this is present in the pet trade. So we're seeing this in a private collection, or in this case in a sanctuary. So put on display, and yeah. So is this dangerous? Not dangerous? What do you think? Anybody has any experience of this bite? JD,
Uh,
Nick?
I don't have.
there's no Gila monster in the Philippines.
Yeah, maybe after this in your dreams you might have, So it's a kind of scramble to look for information. So Rex was consulted, am I right? So we were consulted even before patient arrived to hospital. So this was what we did. We asked for evidence, pictures, and so on, and get the information. So what do you think? What do you think the symptoms patient present? Is she having envenomation or not?
Yes, I do believe there are some.
So she's having vomiting more than just once, abdominal pain, I think, is it? Some other features of parasympathetic as well, diarrhea, if I'm not mistaken. So, and she's bitten twice, meaning possibility of higher dose of venom, envenoming, right? So one bite and then the other bite. Now, one maybe not so much, but the second one is the animal is already too angry, so there could be more saliva goes in. Question is, does Gila monster have a fang like a cobra, or what type of fangs do they have? So this, what do you think? So are we going to look for puncture wounds or fang wound, fang marks, or what kind of injury are we looking at? Do we have a picture of the wound?
There was no picture of the wound, unfortunately.
Okay, I thought
Multiple
there was.
teeth.
Yeah. So in the patient's file there are. Anyway, so management, what do you think?
For
So
Uh,
what's the name? What's the scientific name?
The Heloderma
Yeah,
cut.
the word Gila monster, Gila in Malay is crazy. I don't know what in Philippines. Do you have a no? Not in
no, no,
Tagalog. Yeah,
no, no.
so it's a
Secret.
crazy monster. direct translation. Gila, it means crazy. Yeah. All right. So there are a few species of Gila monster, not that many. So this one of the considered as a venomous lizards in one of the few venomous lizards in the world. So there was a recent case of death from a Gila monster. This is kind of a, after so long, there were no death, and suddenly somebody died in the US from a pet Gila monster while trying to feed the animal as well. So the death was last year, if I'm not mistaken, and so well reported. So they are trying to look again all the components of the venom and so on. So it's not typical kind of like having a fang to deliver. So it's from the puncture wounds that it goes into the secretion goes in. It's not a high pressure kind of a system to deliver venom in such a lizard. Okay. Yeah. So very interesting case. Any progress or what else do you have for us?
So once she presented, this was the initial management that was done. So an IV normal saline of 1 cc per kilogram per hour. So for her body weight, 50 cc's per hour maintenance was maintained for her, and blood investigations was done. So at this point of time, possibly moving on to the patient's progress as well. After 4 hours post-bite, the patient was still having some nausea and vomiting. There was no shortness of breath. There was no chest of pain, and she was able to ambulate to the toilet with no abdominal pain. The pain score was improving at 1/10, and other vitals were as well normal. X-ray was also done and of the left hand and showed there was no obvious foreign body seen post-trauma. So after consultation of Rex as well, this was the further management that was done for her. IV normal saline was still continued, currently increased up to 100 cc's per hour maintenance. Maximum was also given for her vomiting at 10 milligrams 3 times daily. Her ORS was also provided per purge, and she was also given tablet paracetamol 1 gram 3 times daily. An intramuscular tetanus toxoid was also given stat, and upon examination of the hands 4 hours post-bite, it is as of the pictures shown here. The swelling has significantly reduced. There has been minimal pain on the dorsum, and there was full range of motion on all fingers. So possibly could get some of the panelists to give your opinion on the management done currently. Was it adequately done, or was it appropriately managed?
Yeah. York?
Yes, I think so. You have to go for symptomatic treatment. That means you have to treat the nausea and the vomiting, and painkiller and IV fluid to restore the fluid, and so I have in this stage.
Are you worried about any secondary infection or anything like that? You can see the hands very red. It's quite erythematous.
Yes,
Is that because of
I would consider infection. That is true, but I wouldn't go directly on the first day for
Yeah,
antibiotics. Maybe you can
true.
wait
So,
until the next
yeah,
day and see the development, and then maybe add antibiotics on the second or third day when you see that there is the pain.
other signs of secondary. Yeah,
Yeah, yeah.
yeah. So you can see it's quite swollen as well. The finger was beaten there
Yeah.
on the
Yeah.
proximal phalanx. Yeah,
True.
yeah. JD?
Actually, I would actually also agree with what Dr. York has mentioned. Also, maybe I'm not so sure, especially this is the first time I'll be seeing this patient, so I'd rather have a longer period of observation, just
Yeah,
maybe for the standard 6 hours in the emergency department. Number
yeah.
one.
So symptomatic treatment for such
Yeah,
patients. So Maybe we ask for cardiac monitoring as well, maybe a ECG, and possible, tissue necrosis also possible. We don't know, unlikely, but CK might help as well monitor. Anything else, Nick?
The
Yeah.
same,
Okay.
we'll have to watch for compartment syndrome or other signs of infection as well. Yeah.
Okay. Right. So that's the issue here. Is this is a non-native animal, venomous animal. So we have to be aware as well. It's not just that we treat patient with local indigenous species. We are also facing issues like this, where people keep quite dangerous animal in private ownership or in the zoo. But we have to have a bit of information of how to manage such
Yeah.
cases. So this one is, has been around for some time as like a very quite a popular animal to be kept as pets, and it's in the pet trade, and it's now here in Southeast Asia. So for us as medical, we have to know a bit also about the toxinology of the venom from this species. Okay, so that we can. Obviously, there's no antivenom for such a for this species, not even in America. Yeah. Okay, so they consider it as kind of a mild reaction, but it's not really mild. If we have a case of death last year, that kind of changed the whole perception of it being so-called safe pet to be kept as a in private collection. So anyway, so that comes to the question. All right. This is not the only one. We had a few cases before that we discussed on so-called exotic venomous animals in the pet trade in our region. Okay. Right. So in India, a lot of exotic animal as private
Uh,
owners.
Now people have this craze developing to keep all these exotic pets. Like I have seen when I visited Malaysia last time, I've seen such strange animals like in the zoos. The same thing is slowly creeping up in India as well. Like especially our part, they are also started keeping such thing and pet. What do you call it? Pet parks? Yeah.
Yeah. Okay. So how can we progress? How can we proceed for the next?
So yeah, this is the unfortunately this is the only progress that we have of the patient. Uh,
Okay. All right.
Possibly any more input with Prof would like
Any
to give?
questions?
Dr.
No
Khaldoon,
questions.
Dr.
Yeah.
Khaldoon. Yeah, I'd just like to comment is that in this case, I think what really helped Rex in terms of preparing and managing this case is that um, you had already a prior information of what
Mm.
in what lizard you're actually dealing. If
Yeah.
you'd actually ask me a random lizard and then a normal physician will just mistaking it, oh, maybe that's just anxiety and some of the symptoms. And they would
Yeah.
actually
Yeah.
discount the fact that they might actually
Mm.
send this patient home. And I just read this earlier now. Because of the death and there are actually life-threatening complications that some physicians
Yeah.
will actually discharge this early. Our experiences for exotic pets. Recently, we have
Yeah.
this rainbow tarantula that uh, that
Ah.
manifested just like Black Widow envenomation. The good thing
Right.
about the Rex consultation and the network is that you can always call some of your friends. This is the rainbow tarantula
Yes.
is
Yeah.
it's specific. Yeah, the rainbow tarantula is
I would.
specific in India, in I think
Yeah.
southern part of India. I forgot the scientific name of that rainbow tarantula that does these exotic pets. Sometimes they will not actually volunteer the information immediately. But I think as
Yeah.
far as some of our exotic pet handlers are concerned, some of them would really at the least give us the scientific name of what bitten them or what they are actually exposed to.
Yeah.
So
Okay. All right, very good. So that's the importance of networking. I think it helps a lot. I don't know everything, but we
I,
have networks, people
yeah,
that we
I've
can
contact Dr. Ravikar about it. Dr. Ralph. I need
yeah.
your help because we
Ravi.
have this tarantula that we had here.
Yes. Okay. Very good. Okay. So shall we move on? Do we have time?
It's 4:30 right now, Doctor. Prof? In Malaysian time, yes. But we do have a question actually. If we have a question, since in this case, like as Dr. John had mentioned just now, the exotic caretakers. But in this case, where the patient was working at the reptile sanctuary, so can lizard bite be as dangerous as snake bites? And are we underestimating the risk of reptile bite in this occupational setting? What could be done as a preventive measure per se?
Yeah, so the answer is we know the species which are venomous. So in lizard, it's not that many. So one is this particular species. Some people thought that our Varanus salvatore and the common lizard that we have, the monitor lizard, is venomous, but we have still evidence, need to have evidence to say that it is venomous. So some famously say that comment saying that or want to put the Komodo lizard as a on Komodo Island, the biggest the dragon, right? As venomous, but again, it doesn't really reflect from terms of functional use of venom to classify it as venomous. But in this case, yes, it looks like there are some signs in terms of envenoming, and we have death also from the bite, which could lead could be caused from the envenoming. But again, depends on the person as well. So the individual, how they are responding to the envenoming. Some can withstand better than others. Some who may be a bit more immunocompromised and so on, so they might be affected more. So this all depends on a lot of so that we can clearly say that this is actually dangerous to humans. Anyway, yeah. So knowledge-wise, we are able to get, as Dr. JD said, we have a network, so we can get information from. Okay, so it's 4:32. Do we think we have time for another case or not?
I think we can end it here. We have discussed thoroughly a very good file of 3 cases, and I'm pretty sure our attendees, participants, had benefited a lot from this discussion, of course. So I think right now we would want to proceed with a Kahoot session, Prof. Shall we?
Yeah. Yes.
So I think I shall stop sharing my screen, and Prof can take over.
So we do a Kahoot. Everybody is welcome to join. I will share the screen.
So while waiting for Prof to share his Kahoot session for the students joining, please stay till the end because we do have our feedback form and attendances that you are required to fill in for your certificates, and for the doctors joining, GPD points are also provided. So do fill in the feedback form as well. Thank you.
Number 3 is 1, 2, 3. Number 2 is Koi. And the champion is okay. A163239. Please give your details to our moderators for the prize. Okay.
All right. So congratulations and well done everyone for the achievement from the Kahoot quiz. We would like to give a big thank you to our 3 panelists today, Dr. York Blackman, Dr. John David Komadante, and Dr. Nikhil Paul for the amazing compact and concise input throughout the sessions. I hope everyone was enlightened with a deeper depth of understanding about toxin-related injuries now. So thank you also to Prof. Khaldun for accommodating our session today, and we would proceed with the closing speech of this so we would like to invite Dr. John David to give a closing speech. Please welcome.
Okay, so this is actually well, I've given a closing speech well anyways before. So maybe from the panelists here, we'd like to thank the organizers again for always inviting us here, and we're always giving our time, and this is actually a very good activity where we can really teach toxinology and learn from each other. And maybe in the in some cases that would really not know what are you encountering, especially those with envenomations, you should actually really call the Rex so that you would be guided in your treatment and what you do. Of course, for our colleagues here, especially from here in the ASEAN region, we're always very collaborative with the efforts of Rex, and we thank Dr. Khaldun for everything that he has actually uh, uh, given us, at least to collaborate with each other. And I hope that I am pretty much sure that this session will always continue. Maybe I don't know how many years. Hopefully, yeah, that's it.
Thank you so much, Dr. John David, for that lovely speech just now. So we finally have reached the end of our webinar for today. And I would like to thank our esteemed panelists again for joining us today, for giving us your time and input on the cases that we have discussed today. Okay. Thank you so much, everyone. Thank you so much, our esteemed panelists. Thank you, Prof. Thank you, Dr. Nick, if he is still inside as well. I hope all the attendees have joined the session today, and we will hopefully see you in our next episode coming soon. Thank you.
Thank you. Bye-bye.
Thank you.
Thank
Bye-bye.
you. Bye.
Thank you. Bye.